I do it at my computer at work. I'm like, oh, I guess my touch screen is my laptop at home. I'm going to hide transcriptions. Okay.
What is high transcriptions?
Huh?
I mean, mine,
You like seeing the transcript?
no. So my thing at home,
Yeah.
when I'm on PowerPoint, if I'm talking to someone, it all keeps transcribing down here.
Well, is it recording?
Huh?
Is it recording?
Yeah. I don't know how to switch it out.
Well,
Even if I have the TV on, it'll give.
So is that in Teams or Zoom?
No, this is just PowerPoint.
You must have a you must have your microphone on somewhere.
The microphone is on, just like
Well, here, but
computer.
on my computer, the office, I have a transcription button that you can turn on and it will transcribe whatever I'm talking. So maybe that's a button.
It doesn't, it won't keep it, but it keeps on, I just annoying, that's all.
Okay, all right.
We're almost there.
It's 4 o'clock right now, so.
Waiting for Dr. Sami.
Yeah, she's on her way. She was there. She got there about 3:15.
Oh,
No, 3 o'clock.
I mean, it took me 40 minutes to come here. There's some accident down on 65, I think, because it's all backed up. Up. I mean, it was totally, so the 65 people coming from from Indiana, and then the 71,
Yeah.
you know,
Like a model,
and
especially
they
if
all,
going 2 lanes.
so it was backed up.
And I have the party, but Vander says you don't use. Apple. Oh, you don't find this might be the preferred one that you had. Fires. It's okay. But that's what interesting. Thank you. Oh, it's fine. But really, now you've got a lot of stuff going on, parties. It didn't place them. Do we need to? What?
Good afternoon, everyone. Welcome to the Endocrine Grand Rounds today. The last two Endocrine Grand Rounds for the year are special because they are presented by our graduating fellows, an opportunity to talk about some of the work that they have been doing over the last 2 years, and as they graduate to give us an idea of what they're doing. Today we have Mon Nandar, who will be talking to us about bridging the gap, understanding and managing cystic fibrosis related bone disease. Dr. Nandar is a graduate of University of Medicine in Yangon, Myanmar. From there, she went to the UK, where she obtained her MRCP and came to the United States, did her residency at Texas Tech in Amarillo before coming to University of Louisville. Dr. Nandar came with very high recommendation from her residency mentors and has certainly lived up to and exceeded our expectations. She has been an excellent fellow, working hard on clinical aspects and also on scholastic work. She has had many presentations in regional and national meetings. She had the Outstanding Abstract Award at the Endocrine Society last year, and she got the New Investigator Award at the Ohio Region Society of Endocrinology in 2023. She also presented papers at the American Diabetes Association and the American Thyroid Association, and at the Endocrine Society. She has been excellent clinician, and we are very happy that she will be graduating and moving on to a nearby place in Columbus, Ohio, joining the Ohio Medical Group, which is not too far from here. So welcome Mon to present her topic. Thanks.
Thank you so much for the kind introduction, Dr. Mo. Good afternoon, everyone. Thank you for having me today. Do you all hear me well? Good. Okay. So today I'm going to talk about the cystic fibrosis related bone disease. I have nothing to disclose. And this is our learning objective today. One, I'm talking about the pathophysiology of cystic fibrosis related bone disease. And then we'll review the screening, evaluation, and management of cystic fibrosis bone disease. And the last but not the least, we will discuss about the effect of highly effective CFTR modulator on bone mineral density and body composition in adult cystic fibrosis patients. So just to refresh the memory of what is cystic fibrosis, it is an autosomal recessive disorder arising from mutation in the gene encoding the cystic fibrosis transmembrane content regulator protein, CFTR. It's expressed in numerous tissue, but high expression in the airway, small and large bowel, pancreatic, hepatobiliary tract, and male reproductive tract. And the loss of CFTR in those tissues disrupt the regulation of the salt, bicarb, and water balance across their epithelia, and resulting in a systemic disorder with a progressive organ dysfunction. So the disease was first identified in 1938, and at that time, the median life expectancy was a few months. With early diagnosis, by newborn screening program and creation of the referral center to treat and follow the cystic fibrosis patient, the longevity of these patient population is a lot better, and the lifespan is increased to 50 years. Today, the median predicted age of survival for a patient with cystic fibrosis born today is now 56 years, nearly 20 years longer than just a decade ago. The CF population in the United States is now close to 40,000, marked increase over the past decade, with CF patients living longer. They face the new challenges, disease of aging, like a cystic and the bone disease and cystic fibrosis bone disease. So when we look at the epidemiology, when you look at this, there is increase in the adult CF patient population after the 2002, and around 56% is the adult patient population. And when you look at the right side of the screen, in 2022, over the past since 2017, the median age of diagnosis is like 3 months of age, and then the mortality also been declining over the past decade. And as I mentioned, this is a multi-system disease, so the clinical manifestation is including the lungs, GI, liver, and hepatobiliary, and the bone. So today we are going to focus on the bone part. As you can see here, the osteopenia and osteoporosis in adult CF patient was significant percentage compared to the pediatric population. And before the Trikafta, the CFTR modulator therapy, the bone disease are common in the patient with adult CF patient, and the prevalence of osteoporosis is 10 to 20%, and that of osteopenia is 35 to 45%. And vertebral fractures are also reported in 5 to 31% of adult CF patient. And this is really important because the patients will have the thoracic vertebral fractures, rib fractures that cause significant amount of pain, compromising their respiratory function. So a quick review on the normal bone physiology. Bone is a dynamic tissue which constantly undergo resorption and rebuilding throughout our life. going through different stages, starting with the resorption. So our osteocyte sends the micro damage in the old bone, and that kind of send a signal to osteoblast, expressing the RANK ligand, which bind to the RANK receptor on the osteoclast and promoting the osteoclast differentiation. The osteoclast secrete the collagenase and then the hydrochloric acid, making an acidic media to resolve the bone. And as the process going through, and there is a regulation from the osteoblast, that is the osteoprogesterone, which is secreted by osteoblast as well, that kind of bind the RANK ligand, inhibiting the RANK ligand to bind the RANK on the osteoclast, from keeping them from making further bone resorption. And then going through the bone formation stage, where the osteoblast secretes the osteoid, which is the bone matrix, where the calcium and phosphate do mineralization on it and making a hydroxyapatite, making the new bone. And the osteoblast transform into, some of the osteoblast transform into the bone lining cell, and some go into the osteocyte and stay inside the bone. That is kind of like a brief normal bone physiology. So normally the peak bone mass is achieved in the early adulthood, around 25 to 30 years of age. That is influenced by many factors like nutrition, physical activities, gender, time of puberty, and the body composition. So moving on to the pathophysiology of cystic fibrosis bone disease, as this is the defect in the CFTR gene, and that most of the individual carry 2 mutations in the CFTR, most commonly the delta 5FOA, where the others can bring one CFTR mutation, still conferring small amount of residual function. The delta 5FOA is independently associated with the low bone mineral density at both spine and the femoral neck. And CFTR gene dysfunction can negatively impact on the bone formation via the decreased osteoblast number and activation. And also, they found that delta 5FOA CFTR mice also have shown decreased bone formation rate, low bone mineral density, and abnormal bone architectures compared with the control independent of age and sex. A rapid review. This slide is about the various type of CFTR mutation. Several variants of CFTR mutation. There is a classification from class 1 to class 4. When you look at the cartoon on the right side of the screen, you can see the class 1, which is the G542X mutation, that is no synthesis of CFTR protein. Class 2, that is a common one, F508del, and that is defective in the trafficking. And class 3 is G551D, defect in the gating of the channel. And the class 4 is defect in the conductance. And class 5 is a reduced synthesis of the CFTR protein, and class 6 is a decreased stability of the CFTR channel. So by knowing these mutation and the defect, the CFTR modulator therapy can target the specific type of the defect and the mutation. The class 1 and class 3 mutation has significant compromise or reduced CFTR function, so they are associated with the more severe phenotype. So CF bone disease is multifactorial, and due to the chronic organ involvement, I will go detail in the following slide, but mainly the CFBD is caused by defective osteoblast maturation and increased osteoclast formation and activity, resulting in low bone mass and high risk of low impact fractures. There is an interplay between CFTR dysfunction and chronic inflammation. When you look at this inflammatory cytokine, so let's look at this first. So the TNF-alpha interleukin 17 stimulate the NF-kappa B pathway, expressing the RANK ligand, which is promoting the osteoclast activation. And when you look at it, this is the RANK ligand stimulating the monocyte from differentiate into the osteoclast activity, differentiation activity resolving. And the other thing is CFTR dysfunction itself inhibiting the bone formation through inhibiting protection of the osteoprogesterone, OPG, that is through the Wnt beta-catenin pathway. So the first factor that causing the CFBD is the vitamins and the deficiency and the malnutrition. So severe CFTR dysfunction cause the exocrine pancreatic insufficiency, causing the intestinal malabsorption of fat-soluble vitamin K and D. Vitamin K is essential for carboxylation of osteocalcin, which is involved in calcium mineralization for the bone formation, and low vitamin D level impair the calcium absorption, which may result in secondary hyperparathyroidism, increasing bone turnover, result in the low bone density. Malnutrition also can negatively affect on the bone mineralization and difficult to achieve the optimal peak bone mass, and that lead to precociously reduced bone density in adult life. So the next factor is physical inactivities. Mechanical loading is really important for the bone remodeling process because the mechanical signal are transformed into chemical signal, the bone formation pathway and remodeling pathway. So Dr. Garcia group examined the physical activity in 50 CF adult patients using the cardiopulmonary exercise and 6-minute walk test and found significant positive correlations between the activity and the bone mineral density at the spine and the hip. Another one is hypogonadism and delayed puberty. As you all know, the sex hormone is important in the bone accrual and the maintaining bone mass. For example, the estrogen inhibit the osteoclast activity, promote the osteoclast apoptosis. On the other hand, androgen inhibit the osteoclast activity and osteoblast apoptosis and promoting the osteoblast proliferation and differentiation. So Dr. Rossini group also have found that there is a study of 191 patients with CF, and 23% of women and 27% of men has a low sex hormone steroid level. And estrogen level in women correlate with the female low bone density, female bone mineral density, and low testosterone level correlate with the vertebral fractures in men. And delayed puberty also correlate negatively with the BMD as spine, hip, and total body. So another factors play an important role in the CF bone disease is glucocorticoid. CF patients usually receive the glucocorticoid therapy for the pulmonary exacerbation and the post-transplant, and the steroid decrease the bone formation and then increase the bone resorption through various mechanisms. For decreased bone formation, they accelerate the apoptosis of osteoblast and osteocyte, and direct suppression of osteoblast formation. And for bone resorption, they increase the protection of osteoclast via the RANK ligand activation and osteoprotegerin inhibition. And on the other hand, the steroid can impair the intestinal calcium absorption, renal tubular reabsorption of calcium, leading to hypercalciuria and causing the secondary hyperparathyroidism and leading to the rapid bone turnover. And systemic glucocorticoid also decrease the sex hormone production and growth hormone secretion, which also in turn decrease the bone mass. So several mechanisms that causing the low bone mass. The other factor is poor lung function. In patients with CF has shown to correlate with the low bone mass. FEV1 can be a significant predictor of measure of the bone quality and the estimate of the bone strength, and it's also mediated by increased inflammatory cytokine, positive correlation between the number of osteoclasts and TNF alpha and interleukin 6. Another factors is CF liver disease. Has 1.84 higher frequency of CF bone disease compared to the matched control with CF. It is multifactorial, as you can see on the right-hand side. Pretty much overlap with the CF disease itself. CFLD also have these vitamin D, deficiency, low BMD, growth hormone resistant, low IGF-1, hypogonadism, and impact glucose metabolism and causing the low bone mass. It is interesting to know that even with the liver transplant, the bone disease will not resolve. Another area is CF-related diabetes. Diabetes and control that increase the advanced glycosylation and product, increase inflammation, TNF-alpha, reactive oxygen species, and hyperglycemia, lack of insulin and insulin signaling. Also, they affect on both ends by increasing the rank ligand and OBG ratio, potentiate the osteoclast differentiation, increasing bone resorption. And on the other hand, on the osteoblast arm, there is decreased differentiation through reduced transcription factors and also increase the adipogenesis through the increased PPAR gamma pathway. And overall, they decrease the bone formation and then reduce the bone quality. So this is to sum up the factors contributing to the CF bone disease, like pancreatic exocrine insufficiency, vitamin D deficiency, low BMI, delayed puberty, hypogonadism, growth hormone deficiency, or poor growth, CFRD-derived effect on the bone, physical inactivity, chronic infections, steroid use, and CFRD. So moving on to the evaluation of CF bone disease. So the dual energy X-ray absorptiometry is the primary tools to assess the CF bone disease and guiding treatment for the osteoporosis. It is enabled to differentiate between trabecular and corticular bone to assess the bone quality and microarchitectures. The evaluation of the DEXA BMD is based on the T-score and Z-score. T-score is like standard deviation that a patient's BND differ from that of a reference population or healthy subject around 25 to 30 years. Z-score is a standard deviation that the patient's BND differ from that of reference population of the age and sex matched healthy subject. Z-score should be used for the children and the premenopausal women and men under the age of 50. The other complementary tools to the DEXA, you can use the TBS, trabecular bone score, and the vertebral fracture assessment that is validated in CF. For the FRAX, should only use in patient over the age of 40 years. That is not validated in CF patient. Another imaging tools that we can use is the quantitative computed tomography, QCT. They measure the volumetric bone mineral density at the spine and hip. High resolution PQCT measure the volumetric bone density at the tibia and the forearm. So they can differentiate the trabecular bone from the cortical bone and able to assess the bone microarchitecture. Dr. Bootman compared 30 young adult CF patient to 60 healthy control using the HRPQCT. They found the compromised trabecular microarchitecture and then trabecular volumetric bone mineral density and estimated bone strength was compromised in the CF patient compared with the control. So this tool greatly improved the understanding of the bone strength and microarchitecture, but currently is not widely available, and it remains in the mainly in the research institution. And the drawback of this QCT is higher radiation exposure and also more expensive than the DEXA. So this is the comparison between the DEXA and the HRPQCT. As you can see here, the BMD of the lumbar spine are the same in both normal and the CF patient. The bone microarchitectures were poor in the CF patient, but TBS was different, lower in the CF patient. And on the right-hand side, you can see the QCT image of the tibia of 23 years old healthy woman. The bone microarchitectures was looks like this, but for the CF patients, you can see a lot of less poor microarchitectures in the CF patient. So moving on to the lab evaluations, like the usual osteoporosis evaluation and evaluation, we do all these basic labs, CBC, CMP, vitamin D, PTH, 24-hour urinary calcium, and TSH and sex steroid hormone. The right panel is mainly for the selected patient, try to address the secondary cause of the osteoporosis, like thyrotoxicosis or, measure free T4 bone turnover marker as a baseline, and then for the monitoring purpose after they receive the pharmacotherapy, IGF-1, prolactin, celiac screening, and then urine and serum protein electrophoresis, hypercortisolism, RE evaluation, HIV if there is a risk, and then the systemic mastocytosis. So different society guidelines have a different age group for the DEXA screening, which we usually follow the Cystic Fibrosis Foundation guideline. But this paper really show a nice comparison between these guidelines. So CF Foundation guideline started the screening at 18 years of age. If there is a specific risk, they recommend to start at 8 years. So what are the specific risks? Like ideal body weight less than 90 percentile, and FEV1 less than 50% of predicted value, and steroid use more than 5 milligrams per day for more than 90 days, delayed puberty and history of fractures, then they should start the screening at earlier 8 years. And European and the French guidelines, they study at earlier 8 years. And after you have the baseline DEXA, then you do the monitoring based on T and Z score. So for T and Z score more than or equal, more than -1, you do every year, every 5 years. Less than -2, you do every year. The DEXA in between, you do 2 to 4 every 2 to 4 years. A little bit difference in the European and French guideline. They use the Z and the T score. Z for the patient less than age less than 50. The frequency is the same. For the T score, a dead over 50, if it is more than -1 every 5 years, less than -1.5, and history or low trauma fractures, then every year, in between every 2 years. French guideline has a little bit frequent monitoring on the children with a Z score, less than if it is more than -1 every 2 years, if less than -1 every year. And the T score, I think about the same as it's the same as our CF Foundation guideline. And then the other biological measurements on the vitamin D, PTH, and the other parameters. So how do we define the osteoporosis in the cystic fibrosis patient? So usually the cystic osteoporosis is defined when in the patient postmenopausal and men over 50, the T score less than or equal -2.5 or significant fracture history regardless of the T score. But for the young adult and less than 20 years old and premenopausal women and men under 50, the Z score is less than -2 with significant fracture history. Like low trauma fractures of the lower extremity long bones and vertebral compression fractures, 2 or more upper limb long bone fractures, that is defined as the low trauma fractures. So prevention is really important, and then treat with the non-pharmacological measures like optimizing the nutrition and optimizing calcium, vitamin K, vitamin D intake. So the different guideline, society guideline has the specific dosing recommendation depending on the age group. Mostly the European and French almost about the same, but for the Cystic Fibrosis Foundation, CF Foundation guideline, they recommend a higher dosing of calcium, 1300 to 1500 milligram, which is higher than what we usually recommended for the postmenopausal calcium intake of 1200 milligram. And the vitamin D target is above 30, the same with the French guideline, but for the European guideline, they do at least 20 for the vitamin D level, and then also vitamin K supplement as well. And we only have one dosing, but for the European and French, then they do a little bit different dosing based on the age. So when the other areas that we will look at for the bone health outcome in the post-transplant patient with CF, there was a retrospective study at the UT Southwest comparing the 30 adult CF patient who underwent the lung transplant, and then with the 29 lung transplant patient without CF. So what do they found? They found that in the first year post-land transplant, the BMD significantly going down, both spine and the hip. And then there is also post-transplant fractures occur in 30% and 34% of CF and non-CF patients respectively. And CF patients who develop the fractures, they found that they have a lower BMD and lower pre-transplantation FEV1. And so this highlights that there is a unique contribution of the CF disease process to the bone health, as well as the clear need for better prevention of the treatment for the osteoporosis in CF before and after lung transplant. So when do we decide the pharmacological therapy? Obviously, osteoporosis definition have a fractures, then we decide, but depends on the age group. There is a nice categorization of this who to treat, who should consider the treatment. So for the pediatric and adolescent population, if they have the vertebral compression fractures or the BMD Z-score less than or equal -2 and history of low trauma fractures waiting for lung transplant and systemic glucocorticoid for more than 3 months, then should consider pharmacotherapy. For the young adult, the BMD Z-score a little bit different, thresholds a little bit lower, less than or equal -1.5, and the same waiting for the lung transplant and glucocorticoid. But for BMD Z-score less than or equal -2, and the bone loss is 4% or more per year, then you should consider for the treatment. The postmenopausal woman and the man age over 50 is the same as what we are usually doing for our osteoporosis patient in adult. So there are available pharmacotherapy for the CF-related bone disease, mainly the bisphosphonate, which has a pretty much study done on this medication. Like oral form, we have 3 choice like alendronate, rosidronate, ibandronate, and the IV form in the zoledronate and pamidronate. So I'm not going in detail about the dosing, but the maximum duration of therapy you can use for the oral is 10 years, and then you reassess it. And then for zoledronate, 5 years, and then you reassess. And for pamidronate is unknown. So side effect that needs to be discussed with the patient. The oral bisphosphonate can associate it with a reflex esophagitis. IV, they usually have the after infusion, flu-like symptom, myalgia, arthralgia, and also rare side effects like osteonecrosis of the jaw and atypical femur fractures. The other anti-resorptive, like denosumab, not really have much study done on CF population, but you can use, but because this medication is a lifelong, if you are planning to stop, then you cannot stop immediately. Like Dr. Villaforte have the lectures like a week prior. We have a plan for the for maintaining the bone mass that is gained from the denosumab. And the other is the selective estrogen receptor modulator. That is mainly for the postmenopausal woman. They also don't have the data on the CF patient population, but there is an option there if they are in the postmenopausal age, but contraindicated in men and the premenopausal woman. The other anabolic bone agent like teriparatide, abaloparatide, and ramosozumab, they are very limited data. One paper with the teriparatide for patients with the CF, they use the teriparatide and then increase the bone mineral density. Ramosozumab, I think only one patient have tried before. There is no data on the abaloparatide. Time of use is also limited. For the teriparatide, abaloparatide, only 2 years have to be followed with the anti-resorptive medication. Ramosozumab is like 12 months and also need to follow with the anti-resorptive. So to summarize the management of cystic fibrosis bone disease, these are the factors. So every factors need to be addressed carefully for the proper optimization of all these nutrition, vitamin D, calcium supplement, address the hormone replacement therapy for hypogonadism with the hormone replacement therapy, and then CFTR-derived fat on bone use the highly effective CFTR modulator, encourage the physical activity and weight-bearing exercise, minimize the pulmonary exacerbation and steroid use, and also managing the CF-related diabetes or impact glucose metabolism. So this will be the last objective of my talk, CFTR modulator on the bone health. So I think that so there's a study that the CFTR modulator therapies may improve the bone health by targeting the dysfunctional CFTR. And the CFTR is expressed in the human osteoblast, and the CFTR deficient cell demonstrate increased RAN-ligand OVG ratio and reduce the prostaglandin E2, suggesting some tissue level alteration in the bone remodeling pathway. So the key clinical questions about this CFTR modulator is that the CFTR modulator therapy really impact on the bone health? Or does the BMD actually help to predict the future fracture risk in adults and children? So the CF registry data show that the CFTR modulator are used by years from 2014 to 2022. In 2014, the first CFTR modulator ivacaftor was developed, and then subsequent year lumacaftor and then dazacaftor. And then in the late 2019, there is a triple combination of CFTR modulator, elisacaftor and dazacaftor with the ivacaftor, and then that kind of tremendously improved the pulmonary and the nutritional outcome. So how does this work? Let me show the short video clip on how does this CFTR work.
Fibrosis transmembrane conductance regulator proteins, or CFTR proteins, play an important role in moving chloride ions into and out of cells. This movement creates a balance of salt and water. In people with CF, chloride ions don't move like they should because of CFTR protein defects. These defects are caused by mutations in the CF gene. CF gene mutations cause one or both of the following defects. The first defect prevents the proteins from reaching the cell surface. If the proteins do reach the cell surface, the second defect prevents them from opening correctly. This disrupts the balance of salt and water. Without enough salt and water, thick, sticky mucus builds up on the cell surface. In the lungs, bacteria get caught in the mucus, which can lead to infection and inflammation. Now let's turn our attention to Trikafta. Trikafta is a triple combination therapy that adds elexacaftor to tezacaftor and ivacaftor. Together, these three components target certain CFTR protein defects caused by the F508del mutation or another mutation responsive to Trikafta. By binding to different places on CFTR proteins, elexacaftor and tezacaftor get more proteins to the surface. When the proteins do reach the cell surface, ivacaftor helps them stay open longer. With all three components working together, the responsive CFTR proteins can do a better job of moving chloride ions into and out of the cells. This can help maintain a balance of salt and water in certain organs, such as the lungs, which helps keep mucus thin and free-flowing.
So this is a nice video about the CFTR mechanism of action. So for patients who are on the CFTR modulator therapy, they show a significant improvement in terms of the BMI, the nutritional status definitely improved. And most, as you can see here, more than 50% of the patient achieved the goal BMI. And then, in fact, you can see over the past 3-4 years, the obesity, trends start to going up. So how does the CFTR modulator affect on body composition? There was a study done before and after the triple CFTR modulator therapy, combined modulator therapy. So the benefit usually associated with the increased BMI, but there is also changes in the body composition. And that kind of raised concern for the future cardiovascular events. So the weight gain occur not only so mainly in the fat mass. So here, when you can see to the area of fat is increased significantly in the post-Trikafta group, but no significant difference in the total muscle area. So because this is important, traditional nutritional management for the CF mainly focus on encouraging the high intake of high-calorie food rich in fat and the carbohydrates. So if the patients are taking the ETI, the triple combination therapy, they need a new set of recommendations, considering that the should be a healthy weight gain, not the fat gaining of fat mass. So monitoring of the muscle and the body fat component is essential for the CF population. So moving on to the CFTR modulator on the bone density, few papers published, one with the ivacaftor by Dr. Pupen. So she has three different cohorts, one with the ivacaftor group, 26 patients, another 26 CF cohort group, and then 26 healthy volunteer group. So she found that, and then using the HRQ-CT, and then also the area BMD by DEXA scan and bone turnover marker, and then she follow, and then as you can see here, there is an improvement in the cortical microarchitectures in the tibia and the radius, and also improvement in the cortical porosity, but not significant difference in the area bone mineral density and trabecular microarchitecture and bone strength in adult with the CF patient. So there is some improvement in the cortical microarchitecture in adult CF patient with the ivacaftor. So another paper, like a pilot study, then on the 9 Trikafta patient taking Trikafta and the 9 control, they also, but that is only like 3 months after initiation of Trikafta. So they found that the BMD spine and the hip before and after taking Trikafta was improved in the individual patient, and also the BMI improved in that individual patient. So there is no big data on the Trikafta on the bone mineral density and the body composition. So we came up with the idea of we want to look how our CF patients doing with the Trikafta, because most of our patients are already on these triple combinations, and then we kind of want to look on their bone mineral density and then body composition. And so in terms of fat-free mass index and the fat mass index in our CF patient group. And so in our CF clinic, we did the body composition measure with the InBody 570, and then the BMD by the DEXA scan, and then also looking at other parameters, vitamin D and the FEV1 and the other parameters as well. So total of 58 patients were retrospectively reviewed, and then this is their baseline clinical characteristic, mean age of 33, and then mainly Caucasians patient, and then BMI 24 average, and the genotype distribution like this, but I will show in the following slide. And then also the status of pancreatic insufficiency, status of CFRD, and then the status of inhaled glucocorticoid use. So gender distribution, male predominant, 54% is male patient, and then mostly 95% is the Caucasians, and 59, almost 60% are homozygous F508 del mutation, and the 33% is heterozygous mutation, and the other is 8%. The Trikafta starting year is from mainly in 2019 and 2020. So 36% of the patient started Trikafta, and the rest are like 19 and 2021 is 90% and 22 9%. So at least the study population has been on the Trikafta for three years at least. So we look at the baseline BMD, the Z-score, fat mass index, and the fat-free mass index, and the fat mass percent, and the history of fractures. This is the result that we found. So the BMD Z-score distribution is for Z-score less than or equal minus 233% has a low bone mineral density. 40% has the BMD Z-score more than or equal -1, and in between has the BMD in between the Z-score is 27%. So when you look at the mean BMD at L spine and of the control and the tricatheter group, there are not much difference. The same with the left femur, there is also not much difference. So by doing the statistical analysis with the mean and standard deviation, also there is no p-value is more than 0.05 in both the lumbar spine and the left femur. And next is we are looking at the fat mass index and body mass BMI. So fat mass index also increased in the tricatheter group compared with the control, and the BMI also increased compared with the CF control group. And when you look at this on the right side, also they have a significant p-value of less than 0.01 in both fat mass index and the body mass index. On contrary, the fat free mass index, the lean skeletal mass index is like reduced. It is statistically significant reduced in the tricatheter group. So mainly we conclude that the BMI and fat mass index increase in the CF patient taking tricatheter and decrease in the fat-free mass index, but no statistical significant improve in area BMD at the lumbar spine and the femoral neck. So there are limitations in our study because the gender difference within the study cohort and the duration of tricatheter use in relation to the bone mass and the extent of glucocorticoid use among the study subject. So as I mentioned in the prior slide, the CF patient have the abnormal cortical and trabecular microarchitecture and lower volumetric bone density compared with a volunteer healthy adult patient. And then DEXA only measure the area bone mineral density. So HRPQCT probably will provide the unique information on the bone integrity and the microarchitecture that is not fully captured by the DEXA scan. So for the future direction, if HRPQCT will provide the better tools for the bone density assessment, and also the bone trend over longitudinal bone trend over markers trends were probably helpful in the future study. And larger prospective clinical trials are needed to study the efficacy of the tricatheter on the CF bone disease. So final take-home points. So the CF bone disease is a multifactorial disease, so need preventions with the help of multidisciplinary team approach, and then non-pharmacological interventions by promoting the nutrition, calcium, vitamin D, and K, and the weight-bearing exercise, the pulmonary and gonadal status. These are all need to be addressed. And diagnosis of osteoporosis is not only based on the DEXA, but also on the history. And then it is important to evaluate and address the secondary cause of low bone mineral density. And then high-risk fractures patients need a pharmacological therapy. And then last but not the least, the CFTR modulators can potentially improve the bone CFBD via the direct effect on the bone microarchitecture, but indirectly by affecting the overall disease progression. And I would like to acknowledge my program director, Dr. Krishna Sami, and with Dr. Gunarathan for helping us with the statistical analysis, and the whole CF team, CF physician, clinical pharmacy, clinic coordinator, and this month is also the May is the CF awareness month. And this is all the reference that I take. And thank you for listening, and I'm happy to take the questions. Questions?
Is there any mortality and bone disease in CF?
That part, I didn't really look at it. So I'm not really sure if probably indirectly affected. If it is like vertebral compression fracture, wrist fractures, and then respiratory compromise, then with everything's kind of combined together, probably might have some increase in mortality. But current use of the triple combination CFTR modulator really make the difference in terms of the pulmonary outcomes, the nutritional status. So less, bone disease than before, but still probably need to look into that mortality rate. Sure. Dr. Cotwell asked, how is this osteoporosis different from aging-related osteoporosis? So it is as different because it's actually considered as like a secondary cause of osteoporosis because of all the factors that I mentioned in the slide. CF gene itself has an effect on the bone, plus the other inflammatory cytokines, steroid use, the associated CF liver disease, CF related diabetes, that all kind of affecting the bone health. And that's the other question.
Where, if the patients is the response to conventional osteoporosis medication, is it different in the Trikafta people who are on it versus?
Yeah, that is what they are looking for. So that's why more data are needed because the Trikafta data is really scarce in that in the bone field, but there are other like FPV1 improvement, pulmonary functions, also the nutritional outcome improvement. There are a lot of data, but not the scarce data on the Trikafta on the bone health. So that's why we are doing this and see whether we see any difference. But unfortunately, we don't see the area bone mineral density different much. But the pilot study that I mentioned in the slide show improvement in the area BMD, but that is only with the nine CF patients who are on the Trikafta. So I think it's bigger sample will probably answer the question because with the ivacaftor, there is the improvement in the cortical microarchitecture and cortical porosity in 26 CF patients who are on the ivacaftor. So this Trikafta has ivacaftor and the other two Kafta. So hope that it kind of really have the effect on the bone health. Then we just don't have much of data to prove it.
Great job on that. Very, very well done.
Yeah.
Thank you. Took the initiative. We initially started off with looking at the project from when Abby and Dr. Winters did it. I don't know if Dr. Winters is on, but we couldn't get enough of the data that they were looking at their aims. So we went around and finally came up with this question. And like Nandar said, Trikafta is fairly recent. 2019 is when we started. So we'll have more and more data as we go for the impact. And then the QRCT and micro MRI are better at studying that the area of density, especially in the young patients. So that makes a difference. Yes, is there? Is there? Okay. So I wanted him to know that's how we started the project, but then we changed the aim because of what we found here. So
Dr. Winter asked a question about if I understand correctly. you compare Trikafta treated and untreated patients. Do you have any longitudinal data? So I don't have the longitudinal data. This is like a retrospective, like cross-sectional, I would say, in our CF patients. So yeah, we probably need a longitudinal data from starting from, now on, we probably should do the well-structured longitudinal prospective study on this topic. Yeah. No forearm, just the lumbar spine and the left femoral neck. Yes. So mostly the adult CF patient, probably the forearm will be with the HRPQCT they do at the forearm, and the radius and the tibia. But for the DEXA, we only do the lumbar spine and the left femur.
Unless
And the
they
femur.
So you're saying particle.
Yeah, yeah. Yes.
Thank you.
And yeah, thank you. Thanks.